Hi everyone, my name is Ian. Today I'm going to be showing you my thesis that I did at the University of Southern California during my time here. I worked under the Human Performance Lab under Dr. Susan Sigward and PhD candidate Jackie Wong. My thesis is an extension of hers, and I will get a little more into the details about that. That I feel like this thesis is really interesting, especially for clinicians or even in a general biomechanics setting, whether that might be a little bit in sports or that might be in a hospital or a clinical setting as well. So to get into it, the title being R2D estimates the surgical limb knee extensor moment deficits as accurate when using a single versus two cameras. So a little context behind this. We worked with a population of post-ACL reconstructed individuals. They were 3 to 4 months after ACL reconstruction. A little fact about people with ACL reconstruction is that they tend to have knee loading deficits. So meaning that they might have interlimb or interlimb compensations. This is specifically in like weight-bearing tasks. So you might not see this as much in gait, but if we were looking at squatting, it would be pretty prominent. Inter meaning within the limb, so they might be relying on a different joint, and then inter meaning the other limb, so they might be relying on their non-surgical limb to help them get through that movement. Jackie Wong, she had a few aims in her thesis, and one of the aims was looking at 3D motion capture, which is the gold standard because of high validity rate and high accuracy rate. And she wanted to compare it between using two-dimensional cameras on the left side, one on the right side, so the surgical side and the non-surgical side. Well, as a rater and helping him with that part of her aim, we found pretty good consistencies there. And we could say that 2D motion capture would have pretty good reliability and validity when it came to 3D motion capture. And we were like, hey, why don't we take it one step further and try to see if we can do one camera and see if one camera can measure for both views, right? So we're going to have ipsilateral view and the methods down here, where it's going to be the surgical limb and the ground reaction force. And then there's going to be the contralateral, which is the opposite side, right? So for our methods, we had 24 individuals. There was 12 males, 12 female. There was 11 females, 13 males. It was pretty balanced out, left and right. We used you could use really any sort of 2D video capture, just make sure your hertz is correct to what you want to look at. And we used force plates as a reference for centimeters in order to convert the calculations from knee moment extensors to in pixels, which we used image J, as you can see in this line here, right here, this line right here. Here's a little close-up. And then we converted those pixels to centimeters in order to help get our moment arm lengths. So down below, we had two different types of measurements. We had our estimated knee extensor moments, which was taking the moment arm that we drew for the knee joint center, so the lateral epicondyle, and then to the edge of the ground reaction force. And that's how we got our moment arms. Then we got our LSI metrics, which is used for like readiness, and usually used in people with ACL reconstruction, where we compare how ready are they between their non-surgical and their surgical limb. And what we did there is we took the surgical estimated knee extensor moments and then divided by the non-surgical estimated knee extensor moments, EKEMs, which makes sense because what we're doing is we're taking the moment arm length and then we're just multiplying by the ground reaction force, and then we're getting that for the surgical, so non-surgical. So the most confusing part here is because we're trying to use one camera, we're trying to, instead of using two cameras where you have one on the left and the right side, and this time you're only using one view. So we decided to use our ipsilateral side, which is meaning same side, ipsilateral surgical side, right? So this is going to be the camera view facing the ipsilateral side, so the same side of the surgical leg. And the hard part with using one camera is you have to figure out how can we estimate the moment arms on the opposite side, right? So that means, hey, I can't see the contralateral side, meaning the opposite side. So contralateral meaning opposite, since I can't see the contralateral side, I have to use the ipsilateral side to estimate for the ground reaction force. And how did we figure out the difference between the ipsilateral and the contralateral ground reaction force? Well, we had qualysis, where we were able, and we have both, the person had both their limbs on separate force plates, so left limb on the left force plate, right on the right force plate, and we basically measured the ipsilateral knee joint center, what we call peak knee flexion angle, where they're at the lowest depth of their squat, and then we measured it to the ground reaction force. So these are two different ground reaction forces. I'll zoom in, where you can kind of see at the top that this is a little slanted on the ipsilateral non-surgical. So this would be the opposite side. And then the contralateral surgical, right? So right here. So coming to our results after conducting these measurements, we again used ipsilateral surgical as our gold standard. We found that we had underestimations in moment arm lengths in our ipsilateral non-surgical, our ipsilateral, and both our contralaterals and surgical and non-surgicals. Our LSI calculations, we always overestimated past our gold standard, right? So these three are always comparing against the ipsilateral. And we had our three different values. So the ipsilateral surgical to the contra non-surgical was higher than our ipsilateral surgical, and repeating, right? So it got worse the more we were using the contralateral view for each other. You can also kind of see the LSI calculation spread here in our linear regression model, where we could see the Pearson's correlation. And while the results aren't the worst, right, with the Pearson's correlation, we're seeing pretty decent results. This isn't compared, we can't say this is as good as two cameras instead of one to estimate for the other side. So while we do have some decent values, and they do get worse the more we keep going from ipsilateral surgical, contralateral surgical to contralateral sides, we can say, and we can say clearly, while it's less convenient, it is more accurate to use two-dimensional camera views instead of one. And when we used one camera, we had high over and underestimations of our moment arm lengths and overestimations of our LSI calculations. And while the point of this is to say that, well, if you don't really have 3D motion capture, right, because it can be expensive, two cameras will do the same exact job, or, well, pretty similar, close to the same job as a 3D motion capture. I don't want to compare it exactly to it, but what we found from our values and our validation reliability between three raters with two cameras was pretty good successful rate. So if you were on a budget as a clinician or someone in the sports field running a biomechanics lab, you could use two cameras to get those deficits, pretty consistent deficits. But I would not use one camera, because if you also used one camera, it would be inconvenient, as you'd always have to record or have your participant, you have to record and have your participant do the task twice as much if you want to get the right and the left side. So yes, in the end, I just want to say that, again, one camera is not as efficient as two cameras. Even though it's less convenient, I would still rely on 2D cameras, two-dimensional cameras than one